Gunesh, how are you?
2, 1, please start. You are live.
Yeah. Very good evening, everybody. I'm Binish Nambia, General Manager, Oncology, representing BDR Pharmaceutical International Private Limited. On behalf of BDR Pharma, I would like to extend my warm welcome to all the attendees for this virtual international speaker program on rucaparib, a novel PARP inhibitor. Before we set the ball rolling for this scientific session, I would like to set the content for the evening with an opening remarks. BDR is a recognized niche player in manufacturing of pharmaceuticals, APIs, and for our renowned new age formulations. BDR group of companies have grown steadily and become a household name in the pharmaceutical industries over the last 15 years. Innovation and development are the inalienable cornerstones of BDR group. We also have dedicated standalone block for oncology manufacturing plant in India with utmost state of art of R&D center with more than 300 scientists working around the clock. Today, we have gathered here virtually to learn on new aspects and use of novel PARP inhibitor, rucaparib, in clinical treatment settings. I would like to express my gratitude for the presence of our two international speakers and Indian faculties on this ISP meeting. Moving on to the agenda, and that what we'll discuss today, this evening, is role of rucaparib in ovarian cancer by Dr. Robert Coleman and potential applications of rucaparib in gynec cancers in low middle class income countries. We have Dr. Ved, who will be moderating the session with Q&A. And with not taking much more time, we have our program director for today's ISP, Dr. Sudeep Gupta. Dr. Sudeep Gupta is a director for Attract Tata Memorial Hospital, Mumbai. And Dr. Gupta is extensively involved in the principal and investigation of many clinical trials. Dr. Gupta has been in both primary author and collaboration of over 60 previewed publications in national and international journals. In collaboration with other authors, he has written numerous books. He has moved more than 2 decades of experience in the field of medical oncology. He is General Secretary for Women's Cancer Initiative at Tata Memorial Hospital. He has several interests in breast cancer and gynecological malignancies. He has also done extensive research in BRCA1 and BRCA2 mutation in Indian patients. Sir, I would like to invite Dr. Sudeep Gupta for the proceedings. Over to you, Dr. Sudeep.
Good evening, ladies and gentlemen. Thank you, Mr. Nambiar, for your kind introduction. We are all gathered here this evening to discuss the developments in the treatment of ovarian cancer with respect to PARP inhibitors and specifically with respect to rucaparib. I do not need to emphasize to this audience the role that PARP inhibitors have come to play in the management of this disease. We have witnessed in the past few years numerous developments that have now shown us how to use these drugs, when to use these drugs, and what are the most appropriate settings. So without much further ado, I know most of you wish to listen to Dr. Coleman. So it's my privilege and honor to introduce Dr. Coleman, who I have had the privilege of interacting with on numerous occasions in the past. Good evening, Dr. Coleman. Dr. Coleman completed his training at the Northwestern University in Chicago and at the University of Texas MD Anderson Cancer Center more than 20 years ago. I believe about 30 years ago. He served as the Vice Chairman, Department of Obstetrics and Gynecology at the University of Texas Southwestern Medical School at Dallas. And after that, he joined the MD Anderson Cancer Center, where he was a professor and served as the Executive Director for Cancer Research, Cancer Network Research. He very recently in 2020 joined the US Oncology Research as their Chief Scientific Officer. He's extensively published, and of course, all of us know about his research as well as his practice-defining publications in all kinds of journals, including the most impactful ones. He received the 2019 Award for Excellence in Teaching from APGO CREOG. He's a co-director for GOG Partners and serves on the board of directors for GOG Foundation. He's currently the president of the International Gynecological Cancer Society and was inducted very recently into the MJH Life Sciences 2020 class of giants in cancer care. And I think, Dr. Coleman, more than anyone else, you deserve the accolade for being called the giant of cancer care, one of the giants of cancer care. And it is our privilege to have you with us this evening. So let me now stop and I will invite Dr. Coleman to deliver his talk.
Well, thank you so much, Sudhi. It's so great to see you. Thank you for that very warm, kind introduction. It's just so great to see your faces. I just wish I could be there in person to shake your hand and to enjoy your warm hospitality. Yes, thank you so much for this opportunity to present on this topic. Obviously, I've been very close to the development of rucaparib for many years, and I'm really pleased to speak on this topic. And thank you for this kind invitation. Let's hope next time we can be together in person. So my warm greetings to all of you, and I hope that you all stay safe and healthy as we migrate our way through this terrible pandemic, which is keeping us apart, and ultimately love to be with you in person. So these are my disclosures. So, I don't think I need to convince anybody in this room on this conference that DNA damage repair is critical to our business. We are in the business of trying to kill cancer. We do that by causing, unrecoverable damage to the DNA process as one of those mechanisms. And there are many ways that we can do that. Some of these are more toxic than others, and certainly a double strand break to the DNA, it can provide an opportunity for which a cell cannot recover. But as you can see across this slide, there are many of these different mechanisms, and they're governed by a lot of these particular cellular processes that are very important for normal cell survival as well. In fact, it's so important for normal cell survival that the work of these three gentlemen, Thomas Lindahl, Paul Modrich, and Aziz Sankar, quoted in their, as they were working with DNA, that if we did not have these mechanisms for repair, none of us would make it out of our infancy. So the body's innate capabilities to repair alterations to the DNA structure are critically important to our survival. And of course, cancer cells leverage that ability to keep themselves alive. So as these three gentlemen, and they received the Nobel Prize in Chemistry for their description and isolation of these mechanisms, have said, this is critically important. And differentiating our targeting to cancer cells versus normal cells makes therapeutics, cancer therapy, very critical for our patients. So this process of trying to differentiate a cancer cell from a normal cell, and then leveraging these differences in a way that could lead to cell toxicity, cancer cell toxicity, was first demonstrated in these two papers that were published now over 15 years ago. And what I'm showing you on the left is just the IC50 curves for this BRCA2 deficient cell line. So most of you are quite familiar that BRCA2 is one of the two major proteins that governs homologous recombination. And with these cells being deficient in homologous recombination, they showed high sensitivity to a PARP inhibitor. And in this case, you can see that the cytotoxicity of the IC50 for this curve moved about 3 log folds to the left, showing high sensitivity to a PARP inhibitor when there was biallelic loss of the BRCA2 gene. Okay, so that's really important, because here you can see that if both copies are present or one copy is present, these cells do not have sensitivity to a PARP inhibitor. But if there is loss of both genes, then there is cytotoxicity, and that became really important. So why does this work? Well, or why are PARP inhibitors important in this process? Well, what we understand about PARP is that it is a DNA damage repair process, which is efficient in repairing single strand breaks. And so what you're seeing here is a strand of DNA with a break, missing DNA here. And PARP gets recruited to this to the site of single strand break by a number of DNA repair proteins. And because there is a template here that upon which PARP can recognize, we have high fidelity repair of a single strand break because we know what the template read is. So in this case, if there was an A here, T would need to be its partner here, or a G and C would need to be its partner here. So this is quite proficient. But if we interrupt this process, or we trap DNA onto the DNA by PARP onto the DNA by pharmacologically, what we lead to is a probability that a double strand break will take place. Now, as I mentioned, when there is biallelic loss and there's no opportunity to fix this DNA, this becomes a very lethal effect. But in the presence of a normal cell, these processes are intact. And so a normal cell can leverage homologous recombination protein pathway here to provide an opportunity for this double strand break to fix itself. Now, how does it do that? So if you think about it, if there's no template here to read this DNA, how do you know what was missing? So what the body does is it invades one of these, it trims back these segments, as you can see here. So there's a 5' to 3' resection and then there is invasion of the sister chromatid. This is why biallelic loss is so important. So in this particular case, we have an abnormal situation in one gene, and on the other gene, we have an intact DNA. And so what we see here is that there's invasion of the other strand, which provides a template read for this missing strand here. And once the template gets read, then the repair process can happen. And so these, what I've listed over here on the right, are all of the proteins that are involved in this process of homologous recombination, which is what that process is called. So a normal cell with homologous recombination proficiency, or a cancer cell that has intact homologous recombination, the cell can survive this inhibition, which leads to this double strand break. So I hope that's clear. So a double strand break in a patient or a cancer, in a normal cell or a cancer cell that has proficient homologous recombination should survive. Now, on the other hand, if this is broken, then the cell it easily leads to cell death. And so this is super important for ovarian cancer, because if we look at this process again, we find that many of our ovarian cancer cells are deficient in these exact proteins. They're either amplified, methylated, or mutated in about half of the ovarian cancers. So once it was realized that this homologous recombination pathway was so deficient in ovarian cancer, the connection between those two became extremely important for us and our patients. This provided us an opportunity for new therapeutics. And so in 2005, I mentioned that we had our first preclinical in vitro study of demonstrating the cytotoxicity of a PARP inhibitor in the presence of biallelic loss of the BRCA2 gene. And 4 years later, we have a publication in the New England Journal of Medicine of a phase 1 study using one such PARP inhibitor, in this case, olaparib, to show that there was cytotoxicity in cancer patients. And this was done in patients who were BRCA1, BRCA2 germline carriers for the most part. And they broke down in these patients who had had multiple prior lines of therapy in this phase 1 study, what the efficacy was for a PARP inhibitor in patients who had refractory, resistant, and sensitive recurrent ovarian cancer. And you can see the green lines here represent those patients who had an objective response. And although there were, there's less responses the more resistant the patient got, there were still responses seen across the entire spectrum of this collective. So it was not surprising that this new drug entering into which was directed by a biomarker. Okay, in this case, it was the germline loss of BRCA1 or BRCA2, was published in New England Journal of Medicine. And shortly thereafter, this study was expanded across multiple solid tumors, and just demonstrating this for historical reference. In the Bella Kaufman paper, there was almost 200 patients with ovarian cancer who demonstrated a response rate of 31% in patients who had at least 3 prior lines of treatment and carried the biomarker, which is the BRCA mutation. So this was very impressive. And despite the fact that in 2014, there was an FDA meeting which declined acceptance of olaparib as an option for patients with platinum-sensitive recurrent ovarian cancer, they did accept an application for olaparib, this PARP inhibitor, for patients who had recurrent disease defined by a biomarker. Okay, so 2014, we went from this, which was if you look at this, this is the timeline I frequently use to talk about ovarian cancer, where there was just one indication for PARP in patients with ovarian cancer, to today, which is this, which is that we have now approval as both treatment and maintenance in recurrent disease and maintenance in frontline. So we've had a tremendous amount of drug development in a very short period of time. So 2005 lab test, 2009 first clinical test, 2014 first FDA approval, and now in 2021, almost 22, we have 9 approvals or so in recurrent ovarian cancer. So this is very, very exciting. And it basically shows you that in our typical process of drug development, once a biomarker can link itself to the mechanism of a drug, the rapidity of how we can bring these drugs to our patients can be extremely accelerated. And so we've been very fortunate. Now, part of this process was the development of rucaparib. So in 2016, we had completed 2 studies, mostly phase 2, with almost 400 patients. We call these 2 studies Study 10 and Ariel 2. And these studies looked at the role of rucaparib in a slightly different population than was seen for olaparib. In these 2 studies, we were looking for patients who had had prior chemotherapy, including a line earlier in the platinum-based chemotherapies, and that these tumors could demonstrate somatic BRCA mutation rather than just germline. So we had introduced next-gen sequencing to evaluate the role, or to evaluate the loss of BRCA function into this patient population. And many of you may remember that about 3 to 7% of our ovarian cancer patients carry a somatic loss of BRCA in the presence of a germline intact BRCA. So these 2 studies were combined for a data set that was prepared for the FDA approval of rucaparib in patients with ovarian cancer. And this was one of the processes that we now leverage very strongly these days, which is to look at an efficacy population of about 100 patients and a safety population of about 300 patients to bring before the FDA with the intent that we will have a confirmatory trial to prove the efficacy of this drug. So this was the combined results for rucaparib that was in the FDA label in the United States. So you can see that based on the 106 patients that were brought in for this combined assessment, that 54% of these patients achieved an objective response. So this was 3rd line and beyond recurrent, documented a prior response to platinum, and carried a somatic or germline BRCA mutation. Complete responses were about 10%, 45% were partial responses, but the median duration of response was also 9.2 months. So we learned a lot from this study in Ariel 2. You probably saw we just recently published with respect to the toxicity, long-term potential toxicity for MDS-AML, looking for clonal heterogeneity in the cells. We've also demonstrated that once patients develop resistance to a PARP inhibitor, they're unlikely to respond to it directly again. So we've learned a lot from studying this population over the years. But one of the things that we also recognized very early on, and this was to help prove a hypothesis, was that there was a cohort of patients who were BRCA wild type in their germline or in their tumors. but still had high sensitivity to rucaparib. And we called it, at that time, we called it a BRCA-like signature, or LOH high in this particular case, because we used a foundation medicine test that was assessing for loss of heterozygosity as a biomarker for homologous recombination deficiency. And so you can see there's these two classes of patients with BRCA wild type who had this signature versus those that didn't. And what we saw was that there was a differential in the response rate. So as you saw in the previous slide, we had a 54% response rate in patients with BRCA. We saw a 30% response rate in patients who had a LOH high BRCA-like signature, and we saw 13% in patients who did not have the signature. So what it told us was that there was an additional biomarker that was present outside of BRCA. So as we looked into this deeper, what we found was that the presence of the loss of heterozygosity throughout the genome in tumors that lacked BRCA showed up all over the genome. And so what you're seeing here are areas of loss of heterozygosity in a cancer that has a mutation in BRCA. And so we were able to look at wild type patients that had a similar distribution or genotype LOH signature that discriminated themselves from those patients that did not. And so we felt that these LOH high patients probably represented a group that had a BRCA-like condition and would also benefit from a PARP inhibitor. And so when we looked at the ARIEL 2 population with respect to progression-free survival, you can see that we got exactly that. So here is the BRCA patient population. Here is the wild type population. And right in the middle, you can see this LOH high. So this story you guys all well know because it's now entered into our clinical domain. But at the time, this was all pretty new. We didn't really understand exactly why the LOH was a good marker for this, but we now understand that loss of heterozygosity across the genome is a form of a scar. It's evidence that something was wrong, at least at some time in the past. We also learned that the scar doesn't change. So if a patient has a scar and got a response to a PARP inhibitor, but then progressed, and then was retreated with the PARP inhibitor, the scar is still present. It still looks like they should be sensitive, but they don't respond anymore. So it's the separation between historical data and a functional biomarker, which we're still looking for to incorporate into clinical practice. Now, since we had demonstrated already that the fourth line and beyond, and now in the third line and beyond, there was activity with a PARP inhibitor, the next question was, can we move it earlier? As I mentioned, the track for clinical development starts in the resistant patients and moves forward. So it was not much of a, didn't take much imagination to try to move this earlier into lines of therapy. And I always mention this because lots of people say, well, maintenance is different than treatment, but it's really not. If you think about it, most of the patients, and I'll show this in our ARIEL 3 demonstration, most of the patients who went through platinum sensitive recurrent therapy with a platinum-based therapy ended their treatment here with cancer. Okay, so if you start a therapy with the presence of cancer, it's really treatment, although we called it maintenance because they responded. So we came up with this term called switch maintenance, which is a little different than what we think about in terms of maintenance in the frontline setting, where most patients don't have any disease at this point. So, but it was no surprise that if we knew that this drug could shrink tumors in the presence of a treatment kind of paradigm, it should still shrink tumors and potentially be fairly effective in maintaining a response that was achieved by platinum. And that's exactly what we showed. So what I have here are the three trials, the three drugs that were developed in this particular model in recurrent platinum-sensitive ovarian cancer. So rucaparib, you can see here from ARIEL 3, niraparib from NOVA, and olaparib here in SOLO 2. And I've listed all these little subgroups in here and all the median survivorships, and you can go through these if you want. But in general, all I want you to focus on is this red column right here, is the hazard ratio. Now, when as I was going through this, we were happy to see a hazard ratio of 0.7, meaning that there was a 30% reduction in the hazard for progression or death for a drug. And obviously our big winner in ovarian cancer at that time was bevacizumab. So we had shown that bevacizumab given to chemo, in the presence of chemotherapy in the frontline setting demonstrated a huge benefit. And when we saw Aurelia, we got a 0.5 hazard ratio, 0.48. And we thought that was impressive. But then when we did these PARP inhibitor studies and we were seeing hazard ratios of 0.3 and 0.2, were 80% reduction in the probability in the hazard for progression or death was seen in recurrent patients. It was like eye-opening. I mean, to me, it was almost like I remember seeing the first presentation and just almost taking a breath back going, oh my gosh, this is like groundbreaking. And it was. So one of these trials that I was very fortunate to be involved in was the Area 3 trial. And this was a study that was different than the others in a couple of ways. One is that it was a complete cohort of patients with recurrent platinum sensitive ovarian cancer who had responded to their induction platinum. So they were platinum sensitive to start with, so they had a platinum-free interval of greater than 6 months. They went on to platinum-based therapy and they responded. So you can see they responded to the most recent regimen. And they had a CA-125 within the normal range. But we did not restrict the patients if they did not have a complete resolution of tumor. And this is important. Of course, they could have no prior PARP and good performance status. So we randomized these patients 2-to-1 to rucaparib versus placebo. Now, we had a number of stratification factors which have been misunderstood over the years, but I'm glad to be able to present this again because we haven't done this in quite a while. But one of the things that we were interested in is this idea that maybe instead of doing loss of heterozygosity testing, that we could actually look at the gene signature of those homologous recombination genes to see if there was a mutation pattern which could better identify patients who would benefit. So this was a stratification factor, meaning that we had to have this information before we did the randomization. So all these patients had tumor tissue that had undergone next-gen sequencing so that we could stratify them within the cohorts. Again, we also stratified on the basis of their response rate, and we stratified them on the basis of their platinum-free interval. So among these three, this is probably the least impactful stratification factor because at the time we didn't even know this was prognostic, but we had suspicion it was. Now I want to discriminate that from what actually was done in the study with respect to the statistical analysis. So the way this trial was done was that the patients who had a BRCA mutation served as one cohort. And the analytical study over the overall population was evaluated with this population. And if that was positive, then the next analysis was to look at the HRD population. Now, this HRD is not the homologous recombination gene signature I just told you about, which was a stratification factor. In fact, what we did here was to do the next-gen sequencing that was done for the HRR genes and actually look at the loss of heterozygosity. So something completely different. And in that situation, this became this group plus the wild type BRCA patients with LOH high became HRD. And if that was positive, then all of the alpha was passed along to the rest of the population. So you can see these are the BRCA patients, the LOH high patients, the LOH low patients, and the ones that were indeterminate. So this is what's called the hierarchical step-down analysis. And it was one of the first that was done for a complete general population. And you can see here we had 564 patients, and of the BRCA patients, there were 196 BRCA patients out of this cohort, and they were randomized 2-to-1 to placebo versus rucaparib. You can see that most of these patients had a germline, but there were patients who had a somatic variant. The patients that were followed into the HRD cohort was 354. So we added another 158 patients, and these patients had wild type BRCA, but had an LOH high signature. And in the rest of the patients that comprised the LOH low or undeterminate group, you can see we added another 210 patients who fit into this category. Okay, so that's how the population was broken down. And we had a number of secondary endpoints. Most of these now have been reported on, and I'm really proud to be involved with all of those endpoints. So this is the study population. It's, as you expect, about 61 age, median age. Most of them were epithelial ovarian cancer. Most were serous, and you can see the BRCA breakdown here, as I just mentioned. When we look at the actual number of patients with respect to kind of the other demographics, one of the things that we wanted to highlight was that these patients were pretty platinum sensitive. So 60% of the patients in the study had a platinum-free interval of greater than 12 months before they went on to their platinum to go on to the study. And the other piece I want to talk about, because we're going to come back to this, is that most of these patients, 2/3, still had cancer at the end of their last induction therapy. Now, they responded to it and with a normal CA-125, but they still had cancer. Okay, so here were the results of the study. So as I mentioned, the first analysis was to look at just the BRCA patients with either somatic or germline. And you can see there's a huge difference, hazard ratio of 0.23. So 3-fold increase at the median, but even more impressive is this almost 80% reduction in the hazard of progression or death. Now, you have to remember that a hazard ratio of 0.23 means that a patient who starts on day 1 versus a patient who did not start on BRCA on day 1, on rucaparib on day 1, has an 80% reduction in the probability that that patient will have a progressive event. So it's the same, even though there's 100% alive at that point. And on day 2, it's still 80% reduction. And on day 3, 80% reduction. So this proportionately goes out through the entire exposure, so that at 18 months, the patients that are still alive here who are on treatment have, relative to the control arm, have an 80% reduction for the hazard of progression or death. Okay, so it is a substantial effect. So the medians, in my opinion, do not reflect, I think, accurately the impact of making that decision here when you don't know if they're ever going to recur. Okay, all you can tell the patient is that I can give you an 80% reduction in the probability that an event will happen to you in the future. That to me is incredibly powerful. Okay, and of course, because this was positive, we passed that alpha on the analytic plan down to the HRD test positive patients. So these are the patients who were BRCA and the patients who were wild type for BRCA but had LOH high. And you can see the hazard ratio goes up now because it's not quite as effective, but it still is 0.32, representing a 70% reduction in the hazard for progression or death through all of the months of exposure. And of course, since that was positive, all that was passed to the ITT population, and you can see the hazard ratio is 0.36, representing a 60% reduction in the hazard for progression or death. So 80, 70, 60, big, 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 big impact. And again, I don't want you to focus on these medians because they only represent this point in time. But I can tell you at the point in time that you could see this median here at 5.4 months, the patients on the rucaparib arm had a 60% reduction in the probability that they would progress as time went on. Okay, so you got to remember it from, I think of this as something vertical. I think of the vertical connections rather than these horizontal connections, because those are much more impactful to a patient who is on a journey this way. Okay, so we did a couple of some other analyses that I thought which were important. So one, so we carved out these BRCA patients. We looked at just the LOH because I wanted to see whether or not LOH high and LOH low was actually discriminative. And what we found was that was the case. So all of these patients are BRCA wild type. And again, this is a subgroup analysis. They shouldn't have any alpha associated to it. But you can see that the hazard ratio is 0.44 and 0.58, which demonstrated there's a robust effect of rucaparib in patients who have a recurrent ovarian cancer, even in these LOH low. So the question I always get is why? So why is this? And what I'll tell you is that in my opinion, these patients down here that appear to be benefiting where they didn't benefit in the early part of the exposure are probably false negatives. So they have been tested by their LOH signature to be LOH low, and that we're using as a surrogate for intact homologous recombination. But it is probably more likely that they actually are deficient. Because if you can imagine, an LOH score of 13 is below, or excuse me, of 14 is below 16, but that's pretty close to being positive, right? So I think that this group, and we never really got a chance to dig into that much deeper, but I do think that these patients may represent false negatives. Now, one of the very interesting parts to say that lots of people don't remember is that we actually looked at the patient population that had measurable disease at the completion of their chemotherapy. So these were patients who had platinum-sensitive disease. They had they had platinum-sensitive disease. They got platinum induction. At the end of their platinum, they had measurable cancer on their CAT scan, and they met RECIST criteria. So solitary, lesions that had more than 1 centimeter in size, lymph nodes more than 1.5 centimeters on short axis. And we took that cohort of patients. So it wasn't a lot. We had a total of like 200 patients that fit this category. But we actually took that RECIST population and we looked to see whether or not they actually responded. So again, remember I said this is really treatment, not just maintenance? Well, this is the proof of that. So in the patients that have BRCA mutation, we had a 38% response, additional response to the platinum-based therapy that they started with. Okay, and you can see it's about 4 times higher than it was with placebo. And if you look at the HRD and you look at the ITT population, you can see that there is an increase over the placebo population. So I thought that was really an interesting, and it kind of supports my bias that really what we're talking about is treatment. So with respect to the tolerance, so at this time, we didn't have that much experience with PARP inhibitors. We've gotten a lot better with it. Treatment interruptions per protocol were higher in the rucaparib arm, as you can imagine, as is with any study that has some type of toxicity associated with it. We saw some dose reductions in about half of the patients. Fortunately, the discontinuation rate was around 13%. I can tell you that now in most of our common studies that are being done, this rate now is about half of that because we've gotten so much better at taking care of toxicity. The majority of the toxicity was GI, but not that it wasn't bothersome. All of these things can be bothersome, particularly asthenia, which is this like washed out, very tired feeling that sometimes you just need to stop the drug for a while, let the patients recover, and then restart them. We did see some unique characteristics with rucaparib. This is something you just need to be mindful of. We did see early on in the treatment in the first month or two that there was a slight bump up in the LFTs. None of these cases led to Hy's Law. So and none of them were more than this mild elevation over baseline. And you can see that even in the presence of treatment, it kind of went down and it went away, and we didn't see any increase in bilirubin. With respect to the hematologic toxicities, anemia, thrombocytopenia, and neutropenia were all expected. The high-grade components of this are relatively low, especially thrombocytopenia, which was a discriminator against niraparib at the time. And of course, now in 2018, become the basis of this, based on the 2016 approval of treatment of rucaparib in the treatment setting, it got approval in the maintenance setting. Now, there's just been a couple studies. I'm just going to highlight you of where this field has gone. So Ariel 4 was just recently presented. This was a study that was looking at whether or not rucaparib could be as good as chemotherapy, which is a great idea, especially in patients who carry a biomarker. This was done in both platinum-sensitive and platinum-resistant patients. This is a 2-to-1 randomization of rucaparib versus chemotherapy. And you can see in the resistant patients, we used paclitaxel. And in the sensitive patients, we used platinum, either a single or a doublet. This is the overall efficacy population here, which shows a hazard ratio of 0.64, which again represents a significant improvement in progression-free survival against chemotherapy, which was kind of cool. When we looked at the response rate, you can see the response rates relatively close, 40 and 32 between these two. But that was actually, again, still pretty impressive. And this is where it's broken down by the subgroups. As you can remember, in the platinum-resistant group, this is against paclitaxel. And then in the platinum-sensitive groups, you can see it was broken down by this partially platinum-sensitive and fully platinum-sensitive. So again, you can see there's seems to be this kind of different outcome in this partially platinum-sensitive group versus the fully platinum-sensitive group. I don't know what to make of this, to be honest with you, because it's cutting into smaller and smaller components. But this was just the observation of that trial. And then the last thing I just want to mention is about Athena. This one is still not reported. This is a trial that's looking at rucaparib in combination with nivolumab. In the first, and you can see it's 4 arms. 2 of these arms are essentially underpowered or reference. So the first report, which should be coming out later this year, is to look at rucaparib versus placebo in the frontline setting. We think this will be obviously a positive result. And then there's going to be an analysis looking at rucaparib versus of nivolumab versus rucaparib. So, like I said, stay tuned. This will be first to report out very soon, and we're very excited to see the outcome of this trial. So, I want to just leave you with one kind of final point, and this is something I talk about a lot. You may have seen these slides before. But you know, it occurred to me as we watched the natural trend. This is in the United States, of course, of incident rates and death rates with ovarian cancer. They've both been trending in a very common pattern. They've gone down over the last couple decades. But what's really been shocking to me is that the prevalence of this disease has increased. And what does that mean? Okay, incidence is number of cases annually diagnosed per year. Prevalence is the number of women who actually have the cancer at any one time. So if the incidence rate is going down, how can the prevalence rate go up? Well, what happens is that patients are living longer with their disease. And what's really interesting to me is that this big pivot that happened in 2014 coincides with our ability to start using PARP in our patients. And so I really think that PARP has been a game changer for us, and we're so excited to have access to it across the world, because this really matters in the life of our patients. And with that, I'll go ahead and close. So thank you so much for the invitation. I'll stop sharing here for you guys.
Thank you very much, Dr. Coleman, for your excellent talk. And I hope it was very interesting for all of us, interesting session for all of us. And it was a great learning, sir. We shall have a Q&A during panel discussion. I request our audience to please kindly join and put forward your question to learn from Dr. Coleman. Let me introduce Dr. Sandeep Goyale, who is head of oncology at Department Kokilaben Ambani Hospital. He has 17 years of experience in oncology. He did his medical oncology training from reputed teaching institutes in the United Kingdom. And Dr. Sandeep has publication in international and national journals. I now welcome Dr. Sandeep for his proceedings.
Thank you, Binesh. Thank you and thank you, Dr. Coleman, for the wonderful talk. My duty is to introduce Dr. Asima Mukhopadhyay, who's going to give the next presentation. She's a gynecological oncologist, surgical oncologist, and clinical scientist working in UK and also in India. She obtained her MBBS from Kolkata and then an MD from AIMS in Delhi. And then she has got her training in gynecology and obstetrics from UK. She's also got a PhD and an MSc in clinical trials. Her clinical interests include ovarian cancer, cytoreductive surgery and targeted strategies, and translation clinical research in gynecological cancers. She's passionate about setting up cytoreductive surgery units and programs and training in gynecological oncology. And she's a member of many organizations and has got a lot of publications. So I invite Dr. Asima Mukhopadhyay to give a presentation now.
Thank you, everybody. And I'm so sorry, my camera is not working. So I would just go ahead and start sharing my screen. I hope this is visible. All right, is the screen visible now?
Yes, yes.
Thank you. So, so basically, I'm very pleased today to see rucaparib coming to India, because my connection with rucaparib dates back to 2008 when I stepped to Newcastle University as a PhD student before I became a gyne-oncologist, and I landed up with the PARP inhibitor team. We didn't know at that time that the drug, which was developed in Newcastle University, and I have worked on it many, many years, would finally become what you know today as rucaparib. So it's a great feeling for me to be here today and see this finally in India. And I have a disclosure in terms of a royalty payment, but this talk may be conflicted. Basically, there's a big journey, about 20 years of history in how rucaparib was, or with the drug we know as rucaparib has been developed. There is a nice paper by my supervisor, Professor Nicola Carton. A lot of it was actually serendipity, things we didn't know that would give us this desired outcome. And a huge number of people, from chemists, biologists, medical oncologists, somewhere me, being a surgeon or surgical trainee at that point of time. And of course, if you can see, this is a huge number of years that it has taken. The blue ones are the contribution of Newcastle University with the molecule, and my contribution there is about the functional HRD assay showing rucaparib being sensitive to that, and that's back in 2008 before the TCGA data. And just a little bit about this molecule. This NU stands from Newcastle University. So initially it was NU1025 and then NU1085. This was a phosphate molecule and then owned by Agaron before it went to Pfizer and Clovis. But it was the campsylate salt which actually did the trick. And that was after we had sold our IP to Clovis. And some of the data which I'm going to show is very old, but it's very significant in terms of what I'm going to tell you about how it may be useful in its application in low middle income countries, because this is some of the data which we didn't know that it would shape in this way. That the first application, and it's also a radiosensitizer, it can cause potentiation of topo poisons. The first trial by Ruth Plummer, actually using this molecule along with temozolomide, the assay of the PK and PD, which we subsequently used in many studies later on, showing PARP inhibition. Again, another area of serendipity, some data showing this is the Agaron before it became rucaparib with Clovis. Some toxicity data, but some serendipity showed that rucaparib also has some unique property in terms of renal protection and vasoactivity. Of course, we have seen these two back-to-back paper, one of them from Newcastle, but we also looked into HRR beyond BRCA, and this is what my study the first time, 25 clinical ovarian cancer patients, and you can see on the top bar, we didn't know anything about HR at that point of time, but with a twofold rise in RAD51 as a functional, you could see none of these patients responded to PARP inhibitor ex vivo, whereas the ones which did not show increase in RAD51 or HR defect, or HRD as we called that time, only one out of them did show response to PARP inhibitor. One of them did not, the rest of them responded to PARP inhibitors. So basically, we're talking about different assays of HRD, but the way the functional HRD for rucaparib was designed at this time was to detect HR proficiency rather than deficiency. So deficiency was a lack of proficiency, which is a bit different from the other genomic assays that we do today. And it's good to see 10 years down the line that, you know, it's now a recommendation. And there are 3 types of HRD assay. One is a mutational signature, one is a prior HR genomic scarring, which Professor Coleman has just been speaking, and the other is a resurrection of the functional HRD assay, which we have been working over the years. I think from the low middle income perspective, so I think what we're talking about, we really need to do something so that it becomes accessible, affordable, addresses the health inequality. We really need to be judicious in using a targeted agent, not in a non-targeted fashion, because you need to deal with morbidity, resistance, and possibly biomarker-driven approach is more important for low, middle income or low resource setting. and also understanding of the pharmacogenomics and tailored to the patient profiles. Many of our patients have low BMI or are anemic. And we know from our data in Newcastle that the biological optimal dose is much lower than the maximal tolerated dose, which the pharma endorses. And then, of course, we need to review the evidence so far, what and actually what not to do to reduce the elements of PARP inhibitor resistance, because we are not NHS where it gets funded. Basically, there's something else we also need to remember, that in low middle income country, along with survival, is the quality adjusted and or the financial toxicity or economic adjusted endpoints are important. Patients, it's not only the tumor microenvironment, but it's actually the macro environment, which is the logistics, the cost, the lifestyle and all. They can impact on survival rather than the tumor itself. A good biology does not compensate for a bad surgery. So this is very important unless we really go to a stage we have optimized our surgery and basic treatment protocols. I think it's too premature to think about giving PARP. Therefore, we need groups working on it, collaboration, and this is a slide which I devised. So this is what happens in a lifetime journey of an ovarian cancer patient. And I think just trying to address this bit rather than trying to address all the rest possibly is a bit difficult as well. And you will see in high resource setting, everything is more or less addressed, but in low resource setting, this is patchy. And therefore, this is where we need to be innovative to make it cost effective and maybe more selected to specific biological subgroups. Just coming back to the original paper, so we're talking about biological stratification. And I think this is the original of my previous two papers. And I think there are three lessons that I have learned from these. Now I've become a surgeon and looking through the years. But of course, we found that 50% of epithelial ovarian cancers were HRD. Some of my samples went to Foundation Medicine for further validation. But something else which I found that at the point of collection, I didn't know, I was collecting ascitic fluid, whether there was ovarian or subsequently they would turn up to be colon, endometrial or cervical or whatever. But it doesn't matter. If it's HRD, they do respond to PARP inhibitors. The other thing which is important is on the right-hand side, because the assay, the functional assay, was designed to pick up HR proficiency. So we picked up a really bad bunch of tumors with very distinct biological properties that you can't try to reduce them very well because of fibrosis. They're inert, not platinum sensitive. You know, PARP was 0 in that series, in ex vivo, of course. But then we could apply these logics later on in developing a lot of things which I have done in India from 2017 onwards, including developing academic HRD assay, kind of a hub and spoke models. I mean, the cost in our hand for an HRD assay is about $50 to $100, which is minuscule compared to the other available assays that you have. It's difficult to do. There is no doubt about it, but it's workable. And then there are some other unique problems when you think about the HR proficient groups, because the other thing which happens in India, that we have a very strong arsenic belt, and arsenic is a competitive inhibitor of the zinc ring, the zinc finger, which also interacts with PARP. So we really need to know whether we need to do anything in this population. And HR competent cancers, we've been doing a lot of studies thinking about what to do, especially in India, whether we can combine with something else to make it work in this population, because we just can't go unselected. And then the other thing, as I said, there are a lot of other types of homologous recombination deficient tumor types, including cervical cancer, which is different because it's not due to BRCA, but it's the big hypoxic tumors, which has got contextual synthetic lethality. And we have been doing studies in Newcastle, my PhD student, and then a Newton Fellowship fellow of mine. And we have looked into PARP being used in these big tumors where you can't get platinum because of nephrotoxicity to give RAD. And that's the basis of a study which we're coming up. It's called PARP-RAD study. And then the last bit about the other things in ovarian cancer is that in low middle income countries, people are anemic, of low body weight. And then some of the data which we are now, this is the first GCID batch study from India through our group, where we're looking into a strategy called EPIROC, an intermittent PARP inhibitor. And other groups will be joining soon. But then this is based on all this serendipity data, this data from Ruth Plummer, the first time in the PBMCs from a clinical trial, then in xenograft. Basically, we showed that single dose of rucaparib shows a durable PARP inhibition beyond 72 hours. It's actually up to 168 hours, or it's up to 7 days. But what we didn't know, is it only a unique property of rucaparib, or is it the others? So last year, amongst COVID, we got a grant, the TRUK-DBC, and then we did a head-to-head comparison with all the PARP inhibitors. This is, of course, in cell lines, and it appears that amongst the all, rucaparib has this unique property of showing the durable response after a single dosing, and this is not a class effect. And the next one, which would be suitable for intermittent dosing, it would be talazoparib followed by pamiparib. And also we did a study to see the willingness to pay for PARP inhibitors. This is in India, acceptance of detriment, which the patients would accept compared to a situation if they had nothing. And so this is the basis of a study. We're trying to do a phase 2, a short one, start off looking into the biweekly regime first for a response of tolerability. And then, of course, if this is successful, then we would take over. Of course, we have some translational element of looking into the morbidity reduction. We call it more PARP. But then, and then, of course, if it works, then we'll take it to phase 2, phase 3 with, you could do frontline maintenance using intermittent schedules, but using the same principle as we found in our lab studies. Something else that you need to do hand by hand, because it's not only addressing PARP or HRD, you need to handle BRCA and genetics. We have other strategies, and this is also important. Think about what to do with the arsenic belt, whether the PARP will work as it works elsewhere in the where you don't have this problem. And last, a bit of a good news. So the government of India has just launched another Made in India PARP inhibitor initiative, and I'm very privileged to be a part of this as well. So basically, hopefully we'll come up with some better molecules, learn from the lessons, could be generic or new ones with lesser toxicity, lower cost. And also there's a phyto mission looking into the plant-based products with the properties which would mimic rucaparib or the other ones. So with this, I'd like to thank the huge amount of team, funders, and again, thank you very much for allowing me to talk on a molecule which I have worked for many years and I'm still working, and it has got unique properties. So hopefully we would do something for countries, including India, where this is a problem. Thank you.
Thank you very much, Dr. Seema, for your wonderful talk. I'm sure that everybody got enlightened with that. Moving on, I would like to call Dr. Ashok Kumar Vaid, who is the chairman and medical and hemato-oncology at Medanta Hospital, Gurgaon. He has conducted more than 40 international and national studies in clinical research. And more importantly, he has also been honored with the prestigious Padma Shri Award. I now invite and welcome Dr. Vaid as a moderator for the panel discussion to proceed further. Dr. Vaid, yeah.
Thank you, Binish, and thanks everyone on the program, and a very, very warm welcome to all the panelists. And it's an honor to moderate an elite panel of this type. And having heard the two excellent speeches, I think the stage is set for a very exciting panel discussion. There are about 20 odd questions which Vineet had forwarded to me, and I thought let's go as quickly as possible in the interest of time. And I have the privilege of inviting the panelists. Dr. Coleman doesn't need any more introduction. Welcome, Dr. Coleman. Good to see you, and looking forward to welcoming you back in India on a podium soon enough. And welcome Asima Mukhopadhyay. Wonderful talk out there. Dr. Shona Nag, who's the Senior Medical Oncologist, Director Oncology Department at the Sahyadri Group of Hospitals, Pune. Dr. Sandeep, Head of Medical Oncology. We briefly saw him on the program from Kokilaben Dhirubhai Ambani Hospital, Mumbai. Dr. Anita Ramesh, Senior Consultant Medical Oncologist at the HCG Cancer Center, Chennai. Dr. Somashekar from the Manipal Hospital. Dr. Manish Singhal from Apollo Hospitals, New Delhi, and Dr. Sham Agarwal, Navodaya Hospital, Bhopal. I'll share some of the, I'll share my screen and put up the questions out there. So whenever we talk of the PARP inhibitors, it all begins. Can you see my screen, Binish? Is that visible?
Yes.
Yes,
Thank you so much. So everything begins with some sort of a discussion on the recommendations for the BRCA testing and genetic counseling in ovarian cancer. And I thought, let's begin with that. And very quickly, anybody who could take up that, what would be the recommendations as per the NCCN guidelines, and keeping the Indian context also, that the access to all this testing is not as wide spread. And of course, the cost of testing, because out-of-pocket expense is too high. So,
all the epithelial ovarian cancer, yes, at the outset, they should be tested for BRCA testing, and if it is positive, then genetic counseling is must.
So the availability, now that's the problem, the availability of genetic counselors. And I know for someone like Sudeep working in Tata Memorial Hospital, that may not be a challenge. Sudeep, are you there? And but for somebody working in a B town or a C town, though the BRCA testing is become more prevalent and samples are moving from one town to another for testing, but the genetic counseling is something we are really short of. Sudeep, your thoughts on that?
Yes.
Okay.
Yes, Dr. Ved, I did not know that I will. Okay, so I think you are right that we are short of genetic counselors. We are also short of laboratories to test. But one thing that has happened in the past few years is that testing has become more democratic, and you have labs that can collect samples from all over India. And so therefore it is becoming more widely available. And others have also remarked, but I'm reminded of the time in mid-1990s when I used to get a test for HIV done. And, there used to be a big paraphernalia about counseling, etc., and so on. But, that has slowly sort of faded away when we know about the utility of the test. And I think BRCA testing will become commonplace very soon and in the near future. And I think the availability of genetic counselors will also solve itself.
So Anita, the question comes back to you. You were working in a more like a community hospital in a medical college setting, and I see now you have moved into a corporate setting. How do you find the changeover and the availability and the application of these tests? Anita, are you there? So probably, let's move on, and probably Shonana could take that, a brief comment about that before we move on to the next question.
No, so I think as Sudeep rightly mentioned, the availability of testing is really widespread now. and every major town in the country does have a choice of about 4 or 5 different laboratories. Talking about genetic counseling, unfortunately, it's not kept up with the testing. And yes, we have a paucity of genetic counselors, but I'm sure as the demand goes up and more people test, I think that availability will be taken care of too. And while guidelines are just a guide, I think it's important to test the patient as soon as you see the patient. And if you can't do that, at least as long as you do it sometime in the timeline, to be able to offer them the benefit of PARP inhibitors, I think is important.
Very well summarized. Dr. Coleman, we saw in your presentation about the aerial 3, and you know, we know that there is a post hoc analysis on many parameters, and especially the quality of life, the quality adjusted time without symptoms and all that. So these two questions, you know, again, it's a very broad question, though, that your thoughts on the FDA approval of rucaparib, and especially the safety of rucaparib in aerial 3. So if you could, you know, enlighten us.
Sure. Yeah, I hope. Yeah, it was great to be able to talk about the FDA approval process with rucaparib, because I think it in the context that it came, because it was really groundbreaking. And so, you know, the FDA approval process was based on an accelerated approval mechanism, which has been afforded by our FDA to bring promising new drugs to patients sooner. It was initially launched to bring HIV medication to suffering patients, but it has been quickly adopted since 1992 for cancer patients. And so that's exactly what happened. We showed efficacy to shrink tumors in aerial 2 in study 10. And because the confirmatory trial was to use it as a maintenance, a switch maintenance therapy in aerial 3. So that process exists today. It's still the most frequently used process. There's been over 160 drugs that have been tested through this accelerated approval mechanism. So we're very proud of that. And of course it worked. In terms of the safety, you know, we had learned a lot over the years about how to give PARP inhibitors. I think reviewing the safety data from the aerial 3 trial just goes to show you how much ground we've changed and how much ground we've made in learning how to give these drugs. So the treatment discontinuation rates are very uncommon in the real world. We do know that anemia is common as a class effect. This is probably related to the erythrogenesis and the role of PARP2 on erythrogenesis maturation. We know that rucaparib, for instance, has some slight changes on the LFTs, and I didn't present it, but also in the creatinine. And so it's important that that we understand exactly that this is not kidney injury, but actually a form of creatinemia. In other words, loss of excretion of creatinine because of competition with the creatinine transporters in the kidney. Also, not dose limiting, not a problem. But we've just gotten better, you know, dealing with nausea, dealing with the other GI side effects. Like as I mentioned, the most difficult thing, which we didn't really appreciate early on, was that asthenia is really more problematic. And there's no good fix for it other than, you know, dose delay, dose modification. But, you know, most patients, you know, can get through that. But in my opinion, that is the most problematic of the toxicities that we deal with. And it's not just rucaparib, it's all PARP inhibitors where we deal with that problem.
Wonderful. Thank you so much. And Asima, I have a question and an observation from your presentation. You did mention that this is a long-acting drug, and you did talk about a clinical trial sort of a proposal where there could be a drug holiday. And that makes a lot of sense for this part of the world, and where the access, the travel time, and all that. You see a collaborative effort emerging on that front?
Yes, of course. I think the plan is, because it's a GCIG study, so we would be collaborating internationally with other groups like possibly Brazil, but even in India, I think the first phase is crucial because it's got a translational element. So the 40, 50 patients. So I would be kind of inviting people if they have an expression of interest, but that science needs to be proven in a very rigorous way. And then, of course, once it shows, then I think when we go to the phase 2, phase 3 for a bigger study, we really need a lot of collaboration amongst colleagues in India. And so let's just hope that the first phase of study gets done this year, and then we could have a wider collaboration. Of course, without collaboration, we can't do this. And funding, of course. Funding, I think we manage, I mean, we are quite a bit disappointed, or I would say maybe it's quite natural that the pharma will not fund these sort of studies. And therefore, it has been dependent on academic studies like the CRUK, DBT, but due to COVID, the funding was withdrawn. So we are kind of dependent on a little bit of crowdfunding, donation, academic funding, and all that stuff. But hopefully, once this proof of concept is proved, people would see sense of it, and then we can find a way around this.
Look forward to that collaborative effort taking shape. Dr. Somshekhar, you treat a lot of ovarians, and the availability and the application of the next gen sequencing is on the rise. How has been your experience over the last couple of years? Has that increased the access, the availability? Dr. Somshekhar is there?
Yeah, sir, he's having some technical error.
Okay,
I mean,
okay.
yeah,
Sandeep could take this question then.
Thank you. So regarding the ovarian cancer, my take on this is that I normally do BRCA1, BRCA2 and panel for that, but I am not doing the entire next generation sequencing panel for an ovarian cancer patient as of now. So this is what
let me then expand that question to the entire panel. That in India, how many of us are actually doing the next gen and versus the BRCA only and the HRD? So Manish, you work in Apollo hospitals and probably deal with a population which has a better affordability.
And Dr. Ved, I am also here. Sorry.
My apologies, Anita. I did call out earlier.
Yes. Sorry.
No, sure. Please carry on. Take on this question.
Yes, regarding how we do and whether we do. Now, let's straight. If I'm in the medical college, I don't do anything related to BRCA, neither HRD, nothing, BRCA 1 and 2, because logistics is involved. And still not, the drug is not approved by the government scheme, neither in the state government nor in the central government.
So is that the real world scenario in India? What you're describing?
Yeah, it is. See, I see almost 100 cases per day, out of which, medical college becomes 40%. So we don't do it. Now, when I come to a reimbursement sector, I'm also with the ECHS, CGHS, ESI. Yes, 40%. If on that 40%, yes, if I have an ovarian cancer relapse recurrent at once, I will do, because there is logistics is not involved, the drug is available and the testing is available. So I do 100%.
Manish, thank you so much. Manish, the next question about the dosing. Are patients able to tolerate the approved dose of 600 milligrams twice a day? Or do you do a dose sort of a reduction in the beginning and then top it up? Dr. Manish?
Dr. Ved, I'm not finished a little bit. Can I tell about Apollo? I'm also with Apollo Chennai.
So, Anita, we have a lot many more questions on the same coming back to us. Dr. Shona Nag, could you step
yes, Dr. Ved. So Dr. Ved, and I've treated a few patients with rucaparib to date. My strategy is usually to start at the full dose, and there are situations where I've had to reduce it to 400 twice a day, but I persist because I really think with PARP, it's a big, huge learning curve. and you've got to spend a lot of time with your patients. You've got to spend as much time with PARP as with chemotherapy. It's not simple to give, and they are very, keen to give up in the first month or two when they experience that nausea, or they're very tired and they don't know what's happening to them. And then you've got to keep a watch on that hemoglobin. So I've had cases where I've reduced to 400, but after a couple of weeks, I've been able to go up again. So I usually start with the full dose.
Thank you so much. Dr. Coleman, your comments about, should we dose reduce in any set of patients right in the beginning, or go with the prescribed dose? And of course, we know the dose intensity and all that. Would there be a efficacy issue?
So, two questions there. So I generally do not start at a lower dose at the initial regimen if the patients are recovered from their index chemo. So for instance, rucaparib is approved as a treatment and as a switch maintenance. We did run into some problems with patients who started very early after completion of chemotherapy. And we had some more myelotoxicity in cycle 1. So if there's a patient who is recovering from that and you needed to start rucaparib early, you could do a dose reduction. And I'm sure Asima can tell you, we have a large therapeutic window with PARP inhibitors. They are active across a broad range of dosing. So I do not feel that we're providing any detriment in efficacy in lower dose if that's what's required for administration of the drug.
So would you pause the drug for any reason? Patient going for radiation, patient going for
sure,
minor surgery, and how long would you? Because this is a long-acting drug.
Yeah, I mean, I don't think I give patients time. I mean, I've given patients 3 weeks to recover from whatever it is that they need to have. I don't think there's a real problem with that. So, there are some, problem as I mentioned, the most difficult is asthenia. So some patients need a couple weeks of being off therapy to get their kind of back on their feet. And for that kind of a dose delay, I will do a dose reduction as well and then restart.
Excellent. That's a great insight. Thank you so much. So the next question is that can rucaparib be used in patients as maintenance therapy regardless of the BRCA mutation in ovarian cancer? Dr. Anita, so again, linked to the testing and probably, whether in a setting you are describing about where the testing may not be widely applicable, would this drug be used in maintenance regardless? Anita, are you there? So Sandeep, maybe you could take this question.
So, regarding maintenance therapy, usually would be preferred to use in BRCA mutation positive patients. There is some data now to say that you can use that, as Dr. Coleman also showed, that you can use that in BRCA wild type with, in the intent to treat population as well as a treatment option. But I think he'll shed more light on that, whether how beneficial is that.
So Dr. Coleman, we come back to you again on this question, and also the next question as well. I was about to actually come to the next question also, and the about the Ariel 3. We are going back to that trial again and again.
Yeah, I love it. Thank you. So yes, I mean, absolutely. So rucaparib can be used in regards to BRCA mutation. It's approved that way in the United States and many parts of the world. And I shared with you how we did the analysis that showed that in the BRCA, non-BRCA patients, it did demonstrate a difference and it was differentially active in LOH high versus LOH low. So my personal bias with PARP inhibitors in general is that if we had a functional assay of HR compliancy, like the RAD51 assay, if that was available to us, that I probably would not use a PARP inhibitor in a tumor that is demonstrating homologous recombination proficiency, because I don't think it works there in that particular setting, and we have alternatives. However, in the absence of that information, as particularly if it's just BRCA as all you know about, I definitely would use it as a potential therapy. And this risk of progression or death is a is an important reflection of the hazard ratio. So again, as I shared with you on those graphics, I tend to think in vertical lines, not horizontal lines. So that for me, when you're thinking about the patient, before you know what's going to happen to the patient. So the patient shows up in your clinic on Monday and you say, okay, what am I going to give that patient to prevent her risk for dying or progressing 7 months from now? The only thing you can count on is the hazard ratio. You can't count on the median because you don't know if they're going to even make it that far. So that's why I use that to inform my treatment decisions. And I have demonstrated with you that there's about an 80% reduction if you know the patient's BRCA. If they're HRD, it's about 60. And if they're compliant, it's about 50. And if you carve out each one of those individual groups, they're still demonstrating a benefit basically across the spectrum, with the least efficacy in the risk of progression or death is in the patients that have proficient tumors.
Excellent. I think that's a wonderful exposition. Sudeep, if you're there, I would wish you offer your comment also on the maintenance therapy regardless of BRCA mutation, especially in the Indian setup. The drugs are expensive, the testing is expensive, and once you have a negative report, BRCA mutation negative report, would you still use the drug? Any of the panelists would like to offer a comment on that?
Yeah, Dr. Ashok, I'm Dr. Agarwal.
Please.
So, as you said, the testing is very, costly as well as very, time taking. And if a patient can afford rucaparib, with the caveat that we have to, check out the side effects regularly, and if patient is responding without having the test or positivity of BRCA mutation, we can continue with the drug.
Thank you so much. Am I able to connect with Dr. Somshekhar and Dr. Manish Singhal? Are they there on the program? If not, so okay. Yeah, Manish.
Sir, they are just having some technical issues.
Okay, both of them. Okay. So, Shona, I come back to the question about testing, and all of us are concerned about the methodology. Somebody's doing it with a hotspot, somebody doing it with an MLPA, and somebody doing it as a part of the extended next-gen sequencing. Where would you put the perspective as far as our healthcare platform is concerned?
No, so I think NGS has come down a lot in price. And rather than just doing BRCA1 and 2, I do try and opt for a panel. And if I push it a little more, and though MLPA is a little more expensive, you can pick up that additional 3 to 5% of patients that have these large rearrangements. So yeah, I usually opt for a panel along with MLPA testing. And there are controversial issues. I mean, a lot of people will do somatic first, saying that it covers both the germline as well, and then you have a target. But I usually do germline first and a reflex somatic panel testing. So that's the way I approach it in my practice.
Thank you so much. Dr. Coleman, now you're listening to this conversation about the access, pricing, everything. What would it make as a best sense for a health scenario like ours?
Well, I do think that that the best, somebody else asked this question as well, and I do think that the best single test that you can do if it's available would be germline BRCA testing. That as a single test, that provides the most information to you from the standpoint of counseling and from the standpoint of whether or not you could use HRD testing. Excuse me, whether you can use a PARP inhibitor. Remember, if 25% of our patients fall in the BRCA category, and 25% of our patients fall in the HRD category, and 50% of our patients fall in the HRP category. So if you know 1/4 of that pie, you can infer your activity with the rest, right? So so to me, that's the single most important thing. Now, we have looked at patients who have HRD have HRD test negative tumors, but have a BRCA mutation. So they're BRCA mutation, but HR proficient by the HRD test. And the outcome to PARP inhibitors are the same if they had just had HR deficient. So the assay for HR proficiency deficiency is not as strong as the genetic test for BRCA. And the last thing I'll mention is that when we looked at the HRG signature and we looked at 5 different panels of HR response gene mutations, we could not reproduce the impact of a PARP inhibitor with respect to either BRCA alone or with respect to HRD. So right now we haven't solved for the non-BRCA gene mutation part of this.
Thank you so much.
May I make a comment?
Please.
Dr. Ved, I'm sure you're aware that some companies are now offering something known as a HRR, where they are looking at this particular panel of genes for which, like Dr. Coleman says, it's not really approved. But because it's HRR, you could extrapolate using PARP inhibitors. So do you do that in your practice? Are you using that panel?
Please go ahead.
Okay, so far, the only genes that we have found that have the same predictive nature as BRCA have been RAD51C and D and PALB1. Or PALB2. So the other genes, just even though they are mutated, they are not critical to the HR machinery. And so Erica Pujol-Lorraine presented this last year at SGO, 5 different signature panels for the PALA-1 trial to see whether or not they were predictive for efficacy of olaparib and bevacizumab, and none of them, 0, actually were predictive, although the HRD signature was. So, like I said, we haven't really solved for the HRR gene mutation, but I have personally seen responses to PARP inhibitors in patients who have had RAD51 mutations, particularly C and D, and PALB2.
So what you're saying is we don't need a whole bunch of genes. These are the
Correct.
main 4 that will tell
That's
us
correct.
whether we'll get the most for using the PARP inhibitor or not.
That's right. And if you don't have access to those, BRCA is still your best.
All right.
So the BRCA is the way to go if you don't have access beyond that. Very well.
That's what I'm saying.
Now we'll leave out question number 9. We have already discussed a lot about it. And 10, very briefly, we saw in your presentation, Dr. Coleman, that there are combinations, Nivo plus rucaparib.
Yes.
How soon do you expect, these two?
Well, yeah, it's a good question. Not anytime real soon. There are actually 4 trials now that are looking at the combination of immune checkpoint inhibitors with PARP in the frontline setting. So first is looking at niraparib in combination with immune checkpoint inhibitor Duo and OV43. Those 3 are looking at combinations, and then of course Athena. So those are 4 frontline trials. The events are going to be a couple of years away for us before we'll be able to actually see the impact of what PARP plus IO is doing in ovarian cancer.
What's the biomarker for the IO selection in these trials?
Oh my gosh, yeah, that's a whole nother. We're gonna have a whole talk on that. So people are still using PD-L1 status with varying different cuts depending on the actual drug. So for Pembro, we're still using the 22C3 antibody using the CPS score, and for the others, they're using either total positive score and with all different cut points, 10, 50. So it's very difficult. Yeah,
it's an extension of the same science from the other tumor types, which is
right,
and getting more confused because the cutoffs for all the tumors are getting very, very different.
Yes.
So the next 2 questions are interlinked, and this could be taken up by Sandeep. You could sort of throw light on that, and how do you compare Ruca with other PARP inhibitors, and maybe Anita, you could tell us about your thoughts on the safety profile of RUCA versus other PARP inhibitors. Are they really different, or is it the same class of drugs we're talking about?
I think for me, we are still understanding the use of PARP inhibitors. They are recent drugs for us. We are using olaparib, and now we are using rucaparib as well. The experience is still limited. And I think they are similar drugs with certain minor differences with regards to the side effect profile. And I think over a period of time, we would be more comfortable with the use, and also be able to compare and choose our patient that which will go with which drug. Like how we are doing with the CDK4 inhibitors now in breast cancer. I think over a period of time, we'll be doing the same with these drugs in ovarian cancer.
That's a great analogy, I think, And then Anita, if you could, we could have your thoughts on.
Yes. Thoughts on how do you compare rucaparib with other PARP inhibitors?
Your thoughts on the safety profile, of rucaparib.
Okay. Yeah. So yes, I have been using a lot of Limpraza, that is from the AstraZeneca, because that's the only drug which is approved in the reimbursement sector. Yes, it's again, you are right. 30 milligram BD sometimes becomes difficult. We did come down, but relatively the drug is safe. As far as rucaparib is concerned, we have started with 3 patients, and absolutely it is safe, not much of side effects. Rather, I would feel that the asthenia is much lesser than what I experienced with Limpraza. But then apart from this, there is no other notable toxicity to be mentioned at this point of time. Relatively a safe drug, oral medication, and it is patient friendly and also pocket friendly. That's what at this point of time, rucaparib brings its way in the treatment of ovarian cancer.
Thank you so much. Dr. Coleman, any scope of using the PARP inhibitors again, or switching the drugs from one to another?
Yeah, so I very rarely have to switch. For those of you who've had experience with I've had experience with 5 different PARP inhibitors so far. And I have, when you run into problems with a specific cytotoxicity, like platelet for niraparib, or a profound anemia, I will occasionally switch, but I will not switch patients who have progressed. So we have demonstrated pretty clearly that if a patient progresses on a PARP inhibitor, just retreating them with a different one does not work. So the idea of maybe switching or retreating with a PARP inhibitor in a patient who has not progressed, that was kind of the focus of the OREO trial, which suggested there may be a subgroup of patients for which that might be of value, but we still need to sort out exactly which patients might benefit. And that's where I really feel the functional assay for instance, the RAD51 assay is going to be important for us in the future.
So again, please stay on there. And the next 2 questions, are again very interesting. The discussion goes back to testing again and again. And is it for all comers, or is it only for those who test positive for BRCA and HRD positivity? And a very big question is that, an important question is, when we are using them in the first line, how would that modulate our approach in the recurrent setting? Dr. Coleman?
So, as I mentioned, the HRD is a scar. So once it's positive, it'll always be positive, regardless of whether or not those patients are still responding to treatment. So there's not a reversion component to that we could actually test. We don't need to retreat. We don't need to retest if a patient carries a BRCA mutation. So what you're asking is there a functional assay? And I think, as Asima mentioned, we really do need the RAD51 assay to help us know whether or not those patients or the tumors still have activity. The question you just asked about the first line use. So we don't know. The answer to that question is we really don't know. The OREO trial was set up to actually kind of give us that question. And that was a trial that was looking for patients who had previously been given a PARP inhibitor, had been off of a PARP inhibitor, depending on the whether that they carried a mutation or not, for a period of time, then responded to platinum, and then were given a PARP inhibitor versus placebo. And what we saw in that study was that there seemed to be a small benefit to the patients who were retreated with a PARP inhibitor. But this question, will first line affect the recurrent disease, was only a minor component of that study, very minor. like very small percent. So we don't really know the answer to that question, something that we still need to sort out. And that goes with rechallenging. Again, these are all kind of questions that we just don't know because we don't know whether or not patients who never progressed are going to re-respond. But I will say the one thing we do know is if they progressed, they're not going to re-respond.
Thank you so much. So it's like the CPK46 story, which is unfolding in ovarian cancer. Dr. Asima,
Right.
you know, you work in the lab so much, and you have great insight into the basics of the whole biology and everything and the mechanism of these drugs. How can we improve the activity by adding other drugs? What are the drugs which are good to add with PARP inhibitors?
I think if you got BRCA or HRD, which is determined by a proper functional assay, I don't think you should be adding any drugs onto it. And I think if it is, especially in the front line, if it is HR proficient, again, and in true sense HR proficient, then PARP inhibitor will not work through the principle of synthetic lethality. Now, whether it does work through other ways, like something immunostimulation or things for a short-term effect, I don't know. But I think it looks like quite a silly idea to give such a costly drug in a population where you know it might not work, and then try to tame that with something else. I mean, we did start this strategy. I mean, we tried to combine PARP inhibitors with the kinase inhibitors, like the dual mTOR PI3 kinase or imatinib, based on some principles. But what they do reduce the HR or the RAD51 foci, but it is not because they depress the HR, but it's just because they block the cells and going into G1. So actually you see potentiation of the PARP. So it's very tricky in that situation to really add something else. There are certain things which we have found that it may work through different mechanisms, one of them being heat, because it causes transcriptional downregulation of BRCA2. But to add certain things as a maintenance strategy, I think we're not there yet. Immunotherapy, it is maybe something, because PARP does have this immunostimulatory action. So whether PARP makes the immunotherapy work, I don't know. I think it's maybe this way around rather than immunotherapy making the PARP work. PARP is a very powerful anti-inflammatory. Before being an anti-cancer drug, it was used to treat sepsis and myocardial infarction. So it is very, it's a very tricky drug. And I think the danger is if we are not using in a very selected or targeted way. That's all I'll say, and rest I don't know.
Thank you so much. That's wonderful insight. And the next question is, how will you replace rucaparib in treatment setting to olaparib and other PARP inhibitors in BRCA mutation ovarian cancer? Is there a scope to, let me rephrase this question. Is there a scope? And if that exists, is there a possibility of replacing? And anybody could take this question. Dr. Coleman, do you see any scope for that?
Well, yeah. Well, if you're, for me, I've had probably, because I ran, Aerial 2 and Aerial 3, I had a lot of experience with rucaparib. So for me, it was very easy to just incorporate it. I used it about as frequently as I used olaparib, which I had a little bit longer experience with because of the clinical trial domain. But I'm very comfortable with it. I actually like the drug a lot. It's been one of my favorites to use. So I'm not, I think for us, it gets down to reimbursement, is whether or not we can actually replace it in all the settings that olaparib is approved, and that for that minute where niraparib is approved as well. So there are some slight differences in the recurrent setting between those three drugs. But in the frontline setting is where the biggest difference is. And right now we don't have, like, we can't get reimbursed for use of rucaparib in the frontline setting until we get the Athena trial.
So the last two questions are sort of, they're quite interesting and similar to each other. Are there any other indications apart from BRCA mutation ovarian cancer? And getting on to the other side, the HER2 negative early breast cancer, BRCA positive, is there any scope or indications, one could see emerging over a period of time? Dr. Coleman, and we are sorry to interrupt. We are coming to the end of the panel discussion. The last 5 minutes, we have. I would request everyone to give one take-home message and summarize his or her thoughts. So after Dr. Coleman has given his comments on these two questions.
Okay, thank you so much. Well, yeah, I think that I mentioned that with that HRD test positive cases that are BRCA wild type is definitely a case that you would use rucaparib in. At least in my opinion, I would use rucaparib in because I think that those patients respond. As far as across other GYN malignancies, we're still trying to sort out exactly where they fit. Certainly in endometrial cancer, it's of interest, and in some cervix cancer, we're also looking at PARP inhibitions in patients who have other signatures other than BRCA mutation. So that's still work to come. The breast cancer is outside of my domain. I would probably defer to anybody, one of the medical oncologists who has experience with breast cancer.
So Shona, would you?
Well, I think PARP inhibitors in breast is a totally different story. And as we've seen, we've got about 4 PARP inhibitors being tried. We've got talazoparib, olaparib, and each behaves very differently in different settings. And some of the veliparib data is now negative. Talazo is positive in the neoadjuvant setting. Olaparib is both metastatic and early setting. But you don't get the kind of maintenance responses that you get in ovarian cancer. I mean, it's been a little disappointing in breast cancer because they are triple negatives. They progress so fast. They don't just give you a chance. A lot of them have developed brain metastasis by the time, you start thinking of second line PARP and things like that. So it's a very different story.
Thank you. Thank you so much. That's a great insight. And ladies and gentlemen, we come to the last part of the panel discussion, and that's I have the pleasant task of requesting all the panelists to summarize their own thoughts in 30 seconds each. Let me begin with Dr. Shyam Agarwal and a take-home message out of the panel discussion. Dr. Shyam.
Yeah, Ashok, I think with the present scenario, especially in Tier 2 city like Bhopal, I think this is the latest ESCO guidelines have said that regardless of BRCA status, single agent PARP inhibitor, because affordability is better with rucaparib, may be offered to the patient who have not received a PARP inhibitor before, and they are like platinum sensitive relapsed ovarian cancer. We have a lot of such kind of patients. So like regardless of BRCA mutation, if we can use it, it definitely is a boon to the patient and they can have good quality of life.
Wonderful, sir. Anita?
Yes, I think everything has been said by everybody, nothing much to say.
Your thoughts on
yes, again, make it even more cheaper. So that we can use it. We keep discussing, but how many % of the people are able to give the rucaparib? I'm not sure. Yes, in my practice, it's just 10% if I have the cases. So the price again has to come down to a much lower level so that what we discuss, the benefit can be passed on to many.
So I hope Beneath and BDR are listening to that comment by Dr. Anita. That there is still a segment which cannot afford even 10,000 rupees, and the cost has to come down.
There's a huge segment. I second that completely.
Sandeep, your thoughts?
So I feel that PARP inhibitors in ovarian cancer are here to stay, and they play a very important role. especially in as a maintenance therapy, because we get stuck after giving chemotherapy to these patients, and then there's some residual disease, and the patient not really fit to continue with some more chemotherapy or some second line chemotherapy. So that's where I feel that PARP inhibitors will play a very important role, because we have got quite a few patients like these, and if they stay to their promise of in BRCA negative patients as well, then I think that will be a real game changer.
I agree with you. Same thoughts. I echo your thoughts. And Shona?
Well, all I'd like to say is that I think PARP inhibitors are great drugs. And if the going is tough in the first 2 months, don't give up, persist with your patient, and then they seem to tolerate it really well.
Very well. Asima?
Well, I think, my feeling would be that for a country like ours, it's possibly better to go selectively and then urge the government to fund it for those where it works the best.
Thank you so much. Ladies and gentlemen, before I invite Dr. Coleman to offer his comments, and that would be the last, concluding remarks from this panel, I take this opportunity to thank the organizers, Binish and BDR Company, and all my colleagues on this panel, and all the participants who have taken out time. My special thanks to the panelists out here. Dr. Coleman, over to you and your thoughts, and probably like the last concluding remarks.
Well, thank you so much. Yeah, I agree that that PARP inhibitors are the best example of the alignment of a biomarker and a drug, and we should learn from this as much as we can. This is an active drug that has meaningful difference to patients, and so I congratulate BDR for actually figuring out a way to bring this drug to a large group of patients where resources would be constrained. So congratulations to the company. Congratulations to all of the panelists. It's been great to serve with you, and thanks for the invitation to invite me to this.
Thank you so much for those great discussions, all the inputs, and great time for all of us. Back to the organizers. Binish, over to you.
Thank you very much, Dr. Vaid, Dr. Coleman, and really thankful for the wonderful discussion. It was very insightful, very enlightened. I would like to call up Dr. Sudeep for key messages for the entire take-home message. Dr. Sudeep.
So I don't know whether there will be an overload of take-home messages. There have been a lot of take-home messages, and I mostly agree with all of them. I just wanted to say that PARP inhibitors have proved to be a very important drug, a class of drugs in the treatment of ovarian cancer, and we are delighted that BDR has brought one member of that family to India at a cost that is somewhat more affordable than the original innovator drugs. So we are thankful to them. But as a couple of our panelists said, we do need to make them more accessible to more patients. Dr. Coleman, throughout today's evening, has stressed the point that this is a biomarker. There is a companion biomarker in terms of germline and tumor BRCA mutation. There is also the scar of genomic instability, which is not as widely accessible in India. It is expensive. And there are other tests that are not yet fully standardized. And I think we did have some discussion on functional assays, but they are far from being validated for clinical use at the current time. We hope that we will still be able to cull out a group of patients from amongst those who are homologous recombination proficient and BRCA negative, who will still benefit from PARP inhibitors. So I think, but at the current time, my own take is that the biggest bang for the buck in terms of treatment with PARP inhibitors is derived in patients who are either germline or tumor BRCA mutated, or who have a clear evidence of homologous recombination deficiency. And in other patients, as Dr. Asima Mukhopadhyay said, I agree with her that it doesn't seem to be a very cost-effective strategy, at least in India. And also the fact that we have found substantial toxicity with PARP inhibitors in many of our patients. I don't know whether this was adequately discussed, but we do have toxicity, so we need to use this class of drugs and rucaparib in particular with due care and diligence. So thank you very much, and I'm grateful to BDR for inviting me to chair this session, and hopefully we will all congregate soon, perhaps in person, and take it from there. Thank you very much.
Yeah, sir, I really thank you very much, Dr. Gupta, for chairing the session. Many thanks to Dr. Ved for making it more entertaining and with excellent moderation for this ISP today evening, sir. Thank you.
Good, great moderator. Awesome.
Thank you so much.
Yes. Our heartfelt thanks to our international speaker, Dr. Robert Coleman and Dr. Asima. Thank you so much, sir, for giving us your full time and insight of rucaparib. I'm sure our clinicians, our panelists, Dr. Shyam Agarwal, Dr. Anita, Dr. Sandeep, thank you, sir. Thank you so much for your time. We have learned on the treatment aspect of rucaparib in the Indian clinical settings. Our entire faculties for your role in answering the questions. Sir, our chairman's words of accessibility and affordability, we are very sure that we are working on the same line to make it more accessible to all the Indian patients, and we are really work on that, sir. And enjoy the session, sir. We have a lot of participants from Nepal, Dhaka, Sri Lanka, Mexico, Brazil. We all want to, on our BDR's behalf, I would like to thank everyone and making it a successful, sir. Thank you so much. I wish you a happy weekend. Stay safe and good night, sir. Thank you.
Good night. Night, guys. Thank you.
Bye-bye.
Bye-bye.
Thank you.
Thank you.